Okay, we are recording. So my name is Dana Dolan. Hi, I am a contractor working with the Health Informatics team in CDC's Division of Global HIV and TB. Today we're meeting in the context of Shiriki, which is an informal community of people who work in global public health informatics with a focus on HIV and TB. And the conversations that we have in this community are led by members of the community, not necessarily by CDC. Now, if you're not a member of the Shiriki community and you'd like to be one, we have a really brief form that you can use to request membership. I'll post that in the chat in a minute. And if you're attending this session because someone forwarded you the meeting notice, you can use that same form to let us know. So this session is on National Health Data Dictionaries, an emerging framework for implementing health data standards. And following a previous Shiriki webinar regarding concept dictionary governance, global community members and terminology implementers have expressed interest in adopting a National Health Data Dictionary as a method for publishing relevant terminology standards, and aligning in-country health systems on the standards. Today's panelists will describe the work currently in progress, including frameworks and guidance that aim to form the basis for an NHDD implementation toolkit. You are welcome to ask questions using the Zoom chat window. We expect to have some time for conversation as well. And we do ask that you mute your microphone unless you're speaking to everyone. And again, we've allotted 60 minutes for this session, and we'll make the materials available after. So now I'll turn it over to Joseph Amlung of Regenstrief Institute.
All right. Thank you very much, Dana. And hi, everyone. My name is Joe Amlung. As Dana said, I'm from the Regenstrief Institute. I'm a technical advisor there. I'm going to be leading you through a panel discussion today about National Health Data Dictionaries and some of our emerging framework and theoretical materials that we're starting to put together. As we go through, I invite people to put their questions in the chat, and I will be monitoring it and making sure to queue those questions up for our panelists at the end of their respective slides. So just to give a little bit of background, as was stated previously, we had 3 other Shiriki webinars on concept dictionary management, one to give an overview of concept dictionary and going over that with the OpenMRS community, one about giving the kind of current state of concept dictionary implementation, and then one about cross-country collaborations around concept dictionary governance. In addition to that, at the 2023 OpenHIE community meeting in Malawi, we actually had a unconference session specifically about national health data dictionaries, in which we had about 50-ish participants. And you can see a quick picture of that, where countries were able to share their challenges and their ongoing initiatives and things like that related to national health data dictionaries. And I did want to give a little bit of insight from there, just to show you what has been going on with the discussion around national health data dictionaries in the last few months. One in particular is that we've got over 20 countries at least talking about national health data dictionaries and terminology as of this conference, at least. A few to highlight that we've either spoken with directly or have stated their express interest in pursuing a national health data dictionary: Zambia, Malawi, Kenya, Ethiopia, Cote d'Ivoire, Sri Lanka, all have expressed in some way that they want to pursue this national health data dictionary. And one thing that we kind of gleaned from those conferences was that these national health data dictionaries are often starting with a sort of concept dictionary. So I will differentiate those terms later, concept dictionary versus a national health data dictionary. But oftentimes those concept dictionaries are a starting point. We also heard from countries as far as their terminology service deployment, and terminology service is another term that is separate from concept dictionaries and from national health data dictionaries. But as far as the software deployment, the terminology service setup, we had heard from some countries at this OHI conference that had said that it either is present in their strategy document or they've gone further along, they're starting to plan, design, and develop it. That's the most common stage that we had heard, but there are also multiple countries who have deployed a terminology service either in a limited scope or in a region, but we really haven't seen the full national deployment of a terminology service yet. which that to say is perhaps a loaded term, and we may be talking about it later. The full deployment of a terminology service can be an interesting undertaking. So you'll hear much more about that in this session. Additionally, I just wanted to highlight a couple examples of national health data dictionaries. For one, Malawi is wanting to launch a national product catalog. Sri Lanka is wanting to launch a national EHR. Cote d'Ivoire is wanting to focus on lab interoperability from OpenMRS to OpenELIS. And people also expressed challenges with mapping of terminologies, with the governance of their NHDD, with Open Concept Lab and the tooling around managing this, and also talking about data exchange. And there were some challenges down below, as I've shown, that we specifically heard, like how are we working with pharmaceutical terminologies and information? And how do you actually implement a national health data dictionary? And how do we do it sustainably so that this content can remain maintained over the long term? And then how do we integrate with other softwares? Overall, what we learned is that national health data dictionaries are on the rise, and more countries are wanting to subset, publish, and endorse terminology. And so this NHDD concept is starting to gain popularity, with the primary use case seeming to be electronic health records, but other potential use cases including labs, reporting, managing supplies and drugs. And one potential next step is for us to build out some technical use cases, such as using National Data Warehouse as a submission method using NHDD metadata. Before I pass this over to our first panelist, I just wanted to say, where do we see this going? As standards become adopted more globally, there's going to be publication from various groups, and that includes individual countries, that includes standards development organizations such as the World Health Organizations, the LOINCs, the SNOMED groups, and other groups like PEPFAR and WHO who are investing in global health. And so with this large amount of terminology publication, standards publication, we want to make sure we have an idea of how we coordinate and align our respective standard content. So to talk about this more, we've got a great panel for you. So you can see myself up there at the top, and then down below we've got, I will be throwing it to Jonathan Payne from the Open Concept Lab. We will also hear from Dr. Andrew Kanter from the Columbia International eHealth Lab, or CL. And we've also got Steven Wanyee from IntelliSoft Consulting, who does amazing work on the ground in Kenya. So I am going to throw it over to John Payne, and we will get this discussion going.
Good morning, good afternoon, everybody, and thank you, Joe, for the great introduction. I wanted to kind of take the conversation kind of to the next step and talk about an emerging framework for national health data dictionaries. And one of the things that we've learned is that there are a few national health data dictionary projects that have started, and many more that are emerging. And what we are hearing from most of these projects is that there is limited guidance available to support planning and strategic direction for these projects. And I work as a co-facilitator for the OpenHIE Terminology Services subcommunity, and a lot of the discussions related to this and for countries who are pursuing these types of projects does happen in that forum. And so we expect the discussion to continue there beyond this call as well. And I think we'll provide some information about that in a moment here. And so if you can go to the next slide. Several years ago, we created a first framework that was called the Terminology Management Maturity Model. And this identified a couple of patterns that there actually already are some frameworks for the implementation of terminology services that are available, but they're really all looking at the data exchange level. And so once you've gotten to the level of sophistication where you have nationally endorsed terminologies and are beginning to do data exchange already, there's a number of levels of sophistication that you could pass through as you start to implement health information exchange. But many countries are earlier on in the process. They may be exploring data exchange and doing it actively in a certain set of use cases, but we're seeing that many countries are at an emerging level where they are beginning to define and select and endorse terminologies nationally and moving towards this next stage of shared electronic reference. And the shared electronic reference is where you would be able to access the terminology standards that are endorsed for your health system in a structured and standard-based way, but maybe not doing so in a transactional workflow for data exchange directly. And then next would be for digital subscription, where applications that are being used in the health system are actually able to grab those terminology standards from that shared electronic reference and deploy them locally. And we have seen that there is a pretty big climb from the emerging to the shared electronic reference stage. So this maturity model, again, has been very useful for shaping discussions and for helping governments think about where they are and where they want to go next. However, it still didn't provide sufficient guidance for the establishment of a National Health Data Dictionary. Where does a country start? What content should they be looking at? What expertise needs to be at the table? And what leadership and policy frameworks are relevant in this case? So you can go to the next slide. We want to present a framework for National Health Data Dictionaries that is a work in progress, but we believe it's developed enough now that we could use it for discussion here. So a National Health Data Dictionary is a program at the national level led by a Ministry of Health that consists of three different components: governance, content, and software. And so the National Health Data Dictionary program itself, the goal of that is to provide a centralized source for health systems data standards and definitions that provide the common language for exchanging and sharing health information. And there's a number of use cases that Joe showed for why are countries thinking about this. And so on the health side, the use case could be an EHR program, it could be a product catalog, it could be laboratories, could be many other examples too. But the more technical use case for it is to normalize clinical data as it's exchanged to enable more consistent aggregation and reporting and data inference. And so what are these three components? First is the software. Several countries now are using some type of terminology service already, whether in the cloud or they've locally implemented it. A terminology service is the technology that's used that makes those terminology standards that you've published available to your health information architecture. But that's separate or distinct from the content. The content that a country defines and selects and endorses could be reference vocabularies like ICD-11. It could be an interface terminology like CL, which we'll hear more about as well. But there's also value sets and mappings and other types of terminology resources that are really important. And then the third component is governance, which are the policies and the leadership to promote and enforce adoption and the maintenance of the NHDD. And this is typically a nationally designated body that will lead the governance for this. Next slide, please. So let's just take a quicker look at each of these three components. So the terminology service, for people who are familiar with OpenHIE, you will, I guess, already know some about this. It's the architectural component that sits in your HIE that makes terminology standards available in a standards-based way. And there's an architecture specification, and there's a link here that you could follow to find out more information that defines the behavior of that terminology service in your architecture. There's another piece of technology that's often needed here, though, which is the terminology service is what makes it available for data exchange, but some terminology services don't also support the authoring or the management of content at the same time. So sometimes you might need a separate tool to support you in that authoring and maintenance process as well. Next slide, please. The terminology service supports a number of different workflows in your architecture. Here's just a couple examples of, so if you are another application in your architecture, you might say, query the code system and say, is SNOMED available? Is ICD-10 available? There might be a specific code that you want to know, is this part of a code system that we have available? You might translate between a locally used code at a clinic to one of the reference vocabularies like LOIC. But also you might have a value sets defined where you could say, is a value set for maternal health available? And then also retrieve all of the contents of that value set. There are more workflows that are possible and that are defined in the architecture specification for OpenHIE. We encourage you to take a look at that. Next slide, please. So like I said, there's a few countries that have implemented a terminology service already, and that's great. That means that the technology component, the software component, is well on its way. So let's look at the next component, which is content. So what content should a country be focused on publishing and maintaining as part of their NHDD? And there's no one answer for this, and the approaches that countries are using is still evolving rapidly. But let me give you a few ideas. So NHDDs, as we're seeing them, are often beginning with a well-established dictionary that's managed at an organizational level, and where that's being elevated from a program or organization level to become the starting point for data harmonization and normalization nationally. And so Kenya EMR is a great example of that, and we're going to see some more of that from Andy and Steve Wanyee are going to talk about more of it. But that's also not the entire scope of an NHDD. It's just where they start. It's what's providing that catalyst to develop governance processes, et cetera. So a few other considerations. Reference vocabularies and interface terminologies offer many options for how a concept could be modeled, and they also offer lots of terms and definitions that may not be used in the health system. So it's really important for a health system to be opinionated about which concept models are appropriate and which will be understood in the HIE. And because only by being opinionated can you actually do data normalization. And so some examples of that might be different levels of granularity. A diagnosis could be modeled as a yes/no question, or it could just be added to a problems list. There's a number of different examples for why you might need to do this. And but the starting point is for anything that's being reported to the HIE that it needs to adhere to a common standard that's defined in the NHDD. That's what allows the HIE to understand it so that you could clean it, translate it, transform it to the appropriate format as it gets submitted to a national data warehouse. As an example, there are other use cases you might want to use, but I think the national data warehouse is a great place to start. So, but what about data that's not reported to the HIE? Well, the NHDD program should still provide guidance on how to make that interoperability possible in the future. There's a lot of things that could go into this, but a couple of examples: preferred terminology. So if the health system says, hey, like we prefer that a concept be defined in CL, and if it's not, then maybe go take a look at SNOMED, et cetera. But it ensures that there are some norms in the health system for where you should get terms that are going to be used locally. And of course, on the information or data model as well, how should you model a diagnosis? Should it be a yes, no, et cetera? But finally, though, the NHDD must be responsive to what organizations actually do in practice. And this means it's dynamic, it's evolving. Best practices, norms within the health system are always changing, and the NHDD needs to represent that as well. So next slide, please. So there's the terminology from the perspective of an NHDD is hierarchical. There's a relationship between what's defined at the country level, which is this kind of center green box, and if you like looking up towards the global level. And so this would include the red box where there are curated concept sources. This could include interface terminologies or a value set authority. And it's groups that are working globally or regionally that are providing curated sets of content for use. But those are pulling from even the next level up, which is the reference or administrative code sets. And this is things like SNOMED and ICD-11. And so these international standards are used by a country where they are selecting and endorsing certain sets of those and identifying the subsets that are actually being used in the health system that the HIE can understand. But it also goes down towards the organization and facility level, where an organization may not be using all concepts within the NHDD, and they're also trying to standardize and organize how data is being collected and reported in their organization so that they don't have to handle the entire complexity of the NHDD. And the facility level is the same. And a formulary is a great example of where that might look different at every single facility. But you do get a bit of a cycle where as standards are developed and maintained internationally, those get absorbed into the national level health data dictionary, which get consumed then by organization facility level. But there's also reporting back up where the NHDD, like we said, must be responsive to local and national needs. And nationally, they're also providing feedback to global standards organizations to make sure that new concepts, new terms are added as appropriate. Next slide, please. This takes it just a level deeper to show some examples of at each level. In the interest of time, I just want to make one point on this slide, which is that if you look at the bottom where how this might actually work in practice is where application A and B might have different dictionaries that they're using locally to define the metadata or how data is collected and reported in that system. But because they're both aligned with the green country level National Health Data Dictionary, that means when they report data to the HIE, the NHDD could be used to normalize that data and then report it to the National Data Repository. This is conceptually the idea for how an NHDD supports this. The caveat being that it's not enough to just use the right codes. You also have to use a compatible information model, and that's not really being addressed in this diagram. Next slide, please. So the final component, governance. And a governance framework is essential for the ongoing operation of a National Health Data Dictionary. And so let's just look through a few considerations here. This is the piece of the framework that is most under development so far. And so mostly want to just ask some provocative questions to help us all think about how this should continue to develop. So first, about a country needs to decide who is the nationally designated authority that manages the NHDD, what expertise is required, and what are the responsibilities. And so examples of the responsibilities include the selection and endorsement of standards, the management of the dictionary itself, and the customization of standard terminologies as updates are made to say ICD-11, you need to bring some of those items or new codes perhaps into your National Data Dictionary. Next would be, how's the terminology service maintained? So this is thinking about the software and what use cases are supported. The example use case here being the normalization of data reported to the National Data Warehouse. Next is, how do you promote adoption? And so how is the use of the NHDD incentivized and how is it enforced? It might be required in order to participate in the HIE and to report data, or you must revert back to paper manual methods. Things like that would be what this group decides. What guidance and support is available to users of the NHDD? How does somebody start the adoption process? What if you want to subscribe to the NHDD and bring certain codes and terms locally to your own systems? What should that look like? How do you customize a formulary for a specific facility? And finally, how does the NHDD remain responsive to the health system and the changing user needs? How do people submit requests for fixes, a missing concept, things like that? Next slide, please. So the final thing I want to show here is actually a slide from the terminology management maturity model, where this is the type of tool that we expect to develop for the governance component of this, where there are questions that could help a country guide their evolution through the different stages of maturity as they are establishing their national health data dictionaries. This model describes these three subdomains related to content, governance, and use, and where that the governance entity would need to make decisions and provide guidance to the country on these aspects. But more subdomains should be defined as part of this process, and we have started that discussion. And like we mentioned earlier, we invite you to be part of this discussion and the Terminology Services Forum for OpenHIE as this continues to evolve. So, I think that is the end of this section. We can go to the next slide, and I'm going to hand it over to Dr. Andy Kanter, who is going to take a deeper dive into the content in the terminology section of this. So, thank you.
Thanks, Jonathan. That was a really excellent, I think, overview of the many challenges that we have with implementing a National Health Data Dictionary. And I'm going to take just a brief opportunity to try to go into dive into a little bit more detail, particularly from the terminology perspective, as to how can terminology itself ease this process and help allow countries to avoid certain potholes or challenges going forward. As Joe has mentioned, I direct Columbia International eHealth Lab. We provide the CL Dictionary to like 40 different countries. And we can talk a little bit about some of how that experience applies specifically to the National Health Data Dictionary. Next slide. So you're going to see this a lot, and I'm going to really tend to focus on the middle of this to dive into sort of how interface terminology and terminology itself helps develop the NHDD. But I think one of the big challenges is that there are literally millions of codes in the upper dark green, where countries are trying to select from multiple different code systems, multiple levels of granularity. And one of the big challenges is simply trying to move that into the National Health Data Dictionary without understanding some of the challenges that produces for maintenance and for application in the real world. And so we'll talk a little bit about how those middle sections really could be used to help ease that process, make governance choices, and help with the overall maintenance and continuity of the National Health Data Dictionary as it moves forward. So next slide. For folks who didn't see the original presentation on interface terminology or how CL is used in OpenMRS, this is an example is that CL is essentially a dictionary of clinically relevant concepts. And those grew out of the Millennium Villages project back, that was almost 15 years ago now. Was a comprehensive primary healthcare implementation, but very quickly involved HIV, has expanded to include ANC, many of the NCDs, and with COVID and some of the more recent developments of our users, includes areas including specialty care. And what that does is essentially allow countries and users to really recognize the concepts that they need to both take care of patients or public health, but also to report on them. Next slide. And what this dictionary does is actually bridge to the reference code. So instead of having to choose a specific ICD code or a SNOMED code for a particular use case, you're only choosing a concept, in this case, severe headache. And severe headache might be used, like in this case, it's used twice in the ANC or WHO DAC for implementing ANC care. And yet it doesn't actually exist in any of the reference terminologies as severe headache. It's mapped more narrower than to just simply headache in ICD-11 and ICD-10, and even into SNOMED. And you can imagine that if you needed to switch codes between different terminologies, code systems, or if you actually needed to find only the severe headache, you couldn't do it if you simply had an ICD-10 code in your dictionary. Next slide, please. So what we're going to really talk about, and Jonathan described how this National Health Data Dictionary provides this infrastructure for data, not only as it's being exchanged in and out of the national system, but in the process of actually building out interoperability in the country. It bridges between the need for interface, the need for reference and administrative codes, like I mentioned, ICD or SNOMED, and really what exists already in the national implementations or even local implementations of various EHRs and information systems. And so the development of interface terminology is important for essentially bridging the gap between the sort of a top-down approach of the actual codes and what are needed for interoperability, and what the applications need and what the individual use cases need for delivering care or whatever that they are trying to achieve. And the next slide. So let's take an example of how a country might actually utilize terminology and a clinical interface terminology to create a national health data dictionary. So this is just an example. We'll hear more from Steven in a minute, but let's take a representative. Kenya EMR on one side has 750 concepts in its dictionary. Again, these numbers are just for illustrative purposes. And AMPATH over there has 900 concepts, and maybe it's because they have more particular use cases, or there's a research requirement or reporting requirement, and they have more. But this is typically where we start from, right? Is there's already things going on the ground. Next slide. So one of the strategies from initially would be to take a bottom-up approach, which would be to take a look at what's actually being used to identify where there are shared concepts. And the interface terminology is really helpful for sort of matching what is the names of things or the codes that might have been used in one application or another. And it allows you to identify a core subset of things that are needed in more than one place. This also gives you tremendous visibility to what is actually going on the ground, and it prevents this sort of challenge of kind of the academic or a theoretical organization or design being enforced or pushed down onto the real world situation where it's not necessarily appropriate. And so this bottom-up approach allows you to identify what are the key concepts. Now, the common concepts are obviously likely to be included in the National Health Data Dictionary, but the other concepts that are not included actually can be used in the National Health Data Dictionary as a sort of a starting place. So the idea here is that if you're the 200 concepts or the 50 concepts that are not initially shared, if mapped to an international standard via like the interface terminology, then that allows those concepts to be propagated once they are needs to be shared. So instead of countries or implementations developing a new concept that is used, let's say first in AMPATH, and then later gets used in Kenya EMR, and they do it differently, and you create a confusion in the future as you try to normalize that data. They're picking from a central terminology, and that's one of the key roles of an NHDD. Next slide. But the other thing, as Jonathan mentioned, is that from a top-down point of view, is that there are so many different ways to code or model information that you can use the NHDD governance process as a way to make those decisions, to choose which are the preferred method of documentation. So on the left side, you've got the notion of a problem being added to a visit diagnosis or to the problem list. And the question is actually, what is the problem? The answer is, let's say, diabetes mellitus or HIV positive. Versus another model where you might have diabetes mellitus as the question, and then you're asking a question of either yes or no. So that if it's a yes or no question, you have a challenge because now you have maybe a SNOMED code or an ICD code for diabetes in the record, but it's been negated. They actually don't have it. And so you can't just look for the code. You're now having to look for the code and the answer. And these are the kinds of questions that can be clarified in the National Health Data Dictionary depending on the use case. And so this is an example of how a top-down selection of concepts get merged with a bottom-up approach to ensure that the National Health Data Dictionary is serving both purposes. Next slide. So when you look at how this process works, the CL or interface terminology, this published source of concepts, helps bridge the gap to those millions of other standardized codes, and that countries are able to essentially subset, choose what they need out of that larger universe of codes, and do it in a way that ensures that those maps are going to be updated and that they are interoperable with across the not just one country, but multiple countries who need to share data. Organizations then choose that subset of that data as necessary, and they may actually customize. They may find that there are things that they need to do that is just in their local environment that needs to be for their use case, but it needs to be elevated or propagated to the National Health Data Dictionary for eventual sharing. And as Jonathan mentioned, at a facility level, you may even have fewer concepts because you don't have every single drug in the dictionary. You have perhaps only what's in your formulary, and so your local implementation is smaller. But if you're always choosing from the top, you're always going to guarantee that the data is interoperable and that the data is mapped to international standards. But the idea is that as the organizations and facilities, innovate and develop greater specificity or improved quality of care, they're able to propagate upwards to the higher levels, the NHDD that can be shared by other people. Next slide. So ultimately, what the long-term goal is that you've got this sort of shared, centrally governed dictionary where you've got clearly a group of concepts that are shared among all of the applications within the country, but there are these, locally governed dictionaries that have to be mapped to standards and are part of the NHDD so that when the data and information is being shared in the future, you're not having to recreate the same challenge of normalizing the data in the future. So this is the hope is that you're balancing the need for standardization with the innovation and the need for moving forward in an interoperable way. Next slide. Let's skip this one. I'll go to the next because that's just a restatement. So in summary, that the National Health Data Dictionaries can be based on shared standards like CL, and they provide these curated maps and references to and reference and administrative codes. But that isn't going to include all terminology. And so where interface terminology is not available, so maybe you have a local catalog of medical supplies, then you can develop your own reference and admin codes. And this is when the balance between and having good software allows you to do that. So I suggest that you start both from a top-down approach as well as a bottom-up approach to prevent the overwhelming number of codes, as well as having appropriate application to local dictionaries. Sorry, Cyril, if you wouldn't mind muting, that would be great. Finally, organizations and projects should select from a National Health Data Dictionary when creating their dictionaries so their data will be easily interoperable with the National Health Information System. And that actually is important to the governance question. And so Steven will talk a little bit in a moment about that. And finally, as requirements change, so as new concepts are required by your country or your implementations, then international standards really should be used, and they should be added or be considered to be added to the NHDD, not just added to the local application level, because that just kind of kicks the can down the road. And Kenya has been a remarkable example of this process moving forward. And I'm going to turn it over now to Steven to talk a little bit more about their experience on the ground.
And Andy, real quick before that, there is actually a question for you in the chat about use cases that focus on disease surveillance across borders, particularly for countries that are close to each other, such as COVID-19 data collection as a use case. Do you have perhaps a quick answer to that where we've supported that?
Yeah, so that's exactly part of the reason why, as I mentioned before, that both for the Africa Digital Reach program as well as for COVID, there was a need to sort of expand out the national health, to the interface terminology, the CL, to be able to incorporate those kinds of standard codes. And it was an exact example of why like SNOMED and ICD couldn't keep up with the rapidly changing definitions. And so having the interface terminology was there to ensure that the data was being at least captured at that right level of specificity and later mapped to the right the coding systems. So that is really one of the fundamental reasons why National Health Data Dictionaries should be built off of other more global standards so that data can cross borders.
Great, thank you. And Steve, I'll throw it over to you.
Thanks, Joe. I realize we only have about 20 minutes, so I'm not going to take too much time, maybe 5 to 10 minutes, just to get through this country perspective. And so we can go to the next slide, Joe. So basically, I think great presentations and sessions from Joe, John, and Andy, and I think it really makes my work a little bit easier. And so the purpose of my session is just to share our experiences from Kenya. So we've been implementing, or rather we've been using the terminology service, which we call the National Health Data Dictionary in Kenya for slightly over a year, from towards the end of last quarter, last year, 2022, to date. And so this slide attempts to sort of summarize how that experience has been. Of course, a lot has gone on, so this doesn't quite do it justice. But essentially started off with a couple of workshops where, led by the Ministry of Health, the entire health sector in Kenya attempted to really express and demonstrate the value proposition for a technology service, NHDD. And that really sort of came out of, naturally emerged out of some pain points that people are starting to feel, and particularly because there were systems that are getting into the market, especially the public health sector. And people thought that, it was important for us to standardize how technologies were being developed and how they're being used and how they're being managed. And so not that people didn't know about this, but I think was really interesting sort of process where this came up naturally. And so the ministry convened these workshops, and we went through a couple of them until at a point where there was a consensus and the decision by the entire stakeholder community in Kenya to develop a technology service framework, and also sort of harmonize all the data dictionaries that are being used in Kenya, at least starting off with the public health sector. And so to achieve that, the workshop that was held early, the first quarter of last year, 2022, established sort of like 3 main groups. There was a group that was focusing on governance and policy. And this group attempted to, and actually did set up, establish a governance structure, standard operating procedures, roles and responsibilities for the different organizations that were represented. And basically, like Jonathan mentioned earlier, we used the maturity model approach to try and determine where Kenya was at and where we needed to go to, to kind of like get to the optimized state. There was also another group that was dealing with the tooling, and the purpose for this, this group was charged with the task to explore and recommend what tooling options are available, what platforms are available for technology management as we move forward, so that it will be centrally managed by the Ministry of Health. And also to develop an implementation plan for then once the tool or the tooling plus the companion tools were selected, then those would be implemented, and they were actually implemented, deployed at the Ministry of Health data center in Nairobi. And then the third group was on capacity building, and the idea was to develop sort of like do a quick rapid assessment of the capacity in the country that was available at that time and what would be required, and alongside that, sort of develop like I know we used this term back then loosely, a competency framework for what would be required to have the essential capacity, human capacity, to support this service. And so, and we had an ambitious goal of going live by mid of last year, which we actually did. And some of the things that also happened within that time was that there was a lot of transparency, and I would say also very good and competent review of the available options we had to solve this problem. And that's how we selected OCL as a technology management platform or service to use in Kenya. The governance structure, like I mentioned earlier, was set up and appropriately led and managed, led by Ministry of Health and managed through the stakeholder community in Kenya. We also, through, if I was just looking at, I was looking at the implementation plan that we developed back then to operationalize all the good ambitious plans we had. For example, we, like I mentioned, we established the appropriate leadership and governance structure. We operationalized OCL, and we started the process of contributing content, especially led by the key partners in Kenya who are already using SEAL. We started documenting the specifications and requirements as part of that phase one, which people are avoiding use the word piloting, but it was really that trying to explore what would work, what wouldn't work for the entire implementation process. And then a group had started also developing customized training materials, borrowing out of the OpenHIE Academy that already had some of the foundational courses available. And then we had the launch and go live mid last year. And then there was a service support plan that was developed. And I think what we didn't quite manage and probably haven't managed to do yet effectively is the scale up and the post-production evaluation and moving forward. But with all this said, the future looks bright just where Kenya is at. And if you go to the next slide, some of you have seen this diagram. This is what the ministry is articulating or has articulated as its digital health vision, and they're calling it the Kenya Digital Health Superhighway. So this has been developed over the last several weeks, a few months now, and it's been presented to the highest office in Kenya, to the president, basically when he launched the electronic citizen services almost like a month ago. And the Ministry of Health presented this as their vision for transforming healthcare using digital interventions. So what you need to focus on is the middle section here that says the National Core Digital Health Services. And this is what the ministry is really focused on and has prioritized in its vision, to really ensure that all these things are set up and they are robust and they're functional. And there's some very clear sustainability plans to make sure that they keep running for as long as they're required to. So the ones in green have been classified as being available. Green doesn't indicate their status of functionality, but at least they're available. And you can see that then Kenya National Health Technology Service is one of the ones that is available. So it's been recognized, the work we did from last year has been recognized as being available and being important enough as a core service that the ministry wants to optimize and scale up and ensure that all the systems, client systems that are supporting service delivery are using it. So with this vision that is now owned, last week we had a convergence workshop for the whole week. And through the convergence workshop, this was further validated. And the stakeholder group that was invited by the ministry, we had on average of over the 5 days workshop, we had an average attendance of 130 people, representing the key stakeholder groups and partners in Kenya, both from the public and private sector for the first time. We had strong representation from the private sector all throughout the week. And essentially what we did during the convergence workshop week was to take apart all these core services and further determine their current status and in terms of maturity and all that, but also make recommendations of what needs to happen for this to be optimized and to scale up. And so we also looked at the enabling environment that alongside the technical determination needs to work hand in glove for this to scale up and function sustainably over the long term. So the National Technology Service has now very clear recommendations that came out of the group that was focusing on this. And we've started updating the implementation plan. Sort of like looking back into the lessons we learned from last year, and those have informed how the implementation plan looks like. It's a very ambitious plan, and the Ministry of Health and the rest of the government of Kenya offices are very keen to have these core services up and running by December and optimized for that purpose. So we are really happy that this is moving forward and that we're not trying to recreate the wheel. So this conversation comes at a very good time for us. So if you haven't seen this before, please let me know, and we can sort of follow up on what this means. But for those of you who work in Kenya, intend to work in Kenya, this is probably something you want to pay attention to because this is what is now guiding investments in digital health in Kenya and what the ministry really cares about. And if you move to the next slide, the ministry is working through the primary care networks, PCN, that's what this means up here. And ministry has identified and invested seriously in primary healthcare as a way to achieve universal health coverage in Kenya. And so with the broader sort of economic development model and approach that Kenya is using for bottom-up, the interventions and investment the ministry is making in the health sector are starting from the ground up. So one of the things that has happened so far is establishment of the electronic community health information system that is here at the bottom here, that is now in the hands of almost in the hands of 100,000 community health promoters. So we no longer have community health volunteers in Kenya. So now they're promoters, which they're being now recognized as a formal cadre of staff in Kenya. And they've been armed with this eCHIS, which is powered by the Community Health Toolkit, which is a global good, as most of you know. And as part of this digitalization agenda, once it hits the target of 100,000 CHPs using the eCHIS, this will be launched in October during our Veterans Day celebration on October 20th. And eCHIS is already starting to work with the Central Ministry of Health to start utilizing the technology service, or NHDD, and this is what's on the right here. So again, this is just another representation of the previous slide of the core services that are required. But the idea for this was just to show how these central services are being implemented based on the health service delivery model, this so-called PCN model. So it's working through a hub and spoke model where the level 4 facilities in Kenya are the hub. And you know, for example, like in a county, you might find there about maybe 4 level 4s facilities, and then everything else is a spoke. You know, so you've got the level 2s and 3s, and then you've got the community health unit as the spokes to that model. So that's how service is being sort of re-engineered in Kenya to be delivered, and therefore the vision that I showed in the previous slide is working through this model of service delivery. So that's how things are working now in Kenya. And on the left-hand side, there is a real push and interest to develop a patient portal. Again, just make sure that patient care and service delivery is patient-centered. And so patient and portability of patient data is really big right now, right from the community level, and the referral system that if everything works out well theoretically, this, you know, the PCN model should take care of the majority of healthcare needs in Kenya, so that any referrals above level 4, all the way going back to the referral hospitals, will probably be the few, and then that will decongest the health system and also increase the quality of health services provided. So in a nutshell, that's how things look like. And so we are at a point where now we are about to scale up NHDD, learning from the past and also being inspired and motivated by this new vision. Thank you, and back to you, Joe.
All right. Thank you very much, Steve. That was very great. Love to hear the experiences of people who are putting this into real action. So I just wanted to give a very quick wrap up before we go into some more discussion. And I invite people to, once again, please place your questions in the chat and we will queue them up for discussion. Where are we going from here as a community? I just wanted to point out that we are putting together community-driven guidance for concept dictionary reconciliation and how to deploy a terminology service. We are supporting tooling to make sure that people can start to adopt terminology and launch these national health data dictionaries easier. And we are putting together community-driven frameworks, as John had showed us earlier in this presentation, with our terminology service maturity model, and of course, this conceptual framework for NHDDs that we've shown throughout the presentation. If you would like to join the discussion and help contribute to these, or even provide your challenges or questions, we are talking about this in the OpenHIE Terminology Services subcommunity. You could catch us on Friday, August 4th for our next call if you would like to join in on the discussion. So with that, we've got about 5 more minutes. I don't see any questions in the chat. I might prompt a couple of quick discussion questions just to see if anybody has any thoughts on these in particular. One, for the next stage of development in our NHDD framework, what are some real world use cases that could help to push this along, that could help to inform what this framework should be and how it should give guidance? So if you have particular health domains or technical use cases that you would like to push forward, feel free to put them in the chat, or feel free to raise your hand, or maybe our panelists, you have anything in particular you'd like to chime in on this. I do see one raised hand. Isa, if I said your name correctly, could you unmute?
Yes, Joe, you pronounced it correctly. Good afternoon, good morning, everyone, and thank you for this wonderful presentation. I mean, it provides a lot of clarity to what we are doing. So for next stage of development in the National Health Data Dictionary framework, we are currently, sorry, Joe, I am the team lead, Health Informatics and Health System Strengthening, CDC Nigeria, so that when I mention something you are aware of. So I know you are aware of the OCL mapping that we're currently rounding up down here in Nigeria. And I think I have a couple of questions around the OCL. First of all, I know the relationship between the National Health Data Dictionary and OCL is, like you mentioned, OCL has the global terminologies. So each country will have their specific minimum data set kind of that will be, mapped to what we have, on the OCL. And I know it is documented around this having standard data as benefit of OCL using common terminology is critical for knowledge sharing across multiple locations, multiple digital health systems. My question is, this is something that is dynamic. So how often do you anticipate updates into OCL generally? And how are these updates, if any, communicated to different countries? The second question is, when there are emerging public health diseases of public health importance, let me give an example with COVID. Needs arise to document this electronically, depending on which country come first to have this implemented. How do you receive such updates from countries and relate it to the global community, such that if another country want to key in, it's already been updated on OCL and it's already having unique terminology or concept ID that anyone can just key into it and bring it down and map it to their own specific systems. Thank you, and over.
And I think that's actually a very good question. I might have some thoughts, but also Andy, I know that you are often managing these new requests that are coming into the CL terminology and we push them into OCL. Do you want to say anything about how you're receiving these updates and how you're trying to be responsive to countries?
Sure, and I think Jonathan can talk also about just in general the OCL strategy for maintaining and refreshing content. But CL, for example, puts out new content every month. And that involves oftentimes extensions to what you might consider people want to put in their national health data dictionaries because of local use cases. So as Partners in Health or MSF or Kenya EMR needs new concepts in their national health data dictionary that they cannot find either in SNOMED or in CL, then we'll be creating new concepts every month, and they're available in the CL, in OCL to CPC. But when something like COVID happened, and you can actually, I put the link in the chat, but there's a specific subset of COVID-related terminology, which is actually included in CL, but we wanted to call out for people who wanted to quickly get the change, essentially the updates needed to do that, the challenge, the disease of public health importance. And so what happened was we produced that the COVID subset, and you can actually see there, every time a new variant, for example, came out, there was a code released there so that a national dictionary or an application would be able to capture that information, even though there was no granularity to support that initially in ICD or SNOMED, but they are there for capturing, and then eventually as those get created, those can be added in the back end after the fact. Jonathan, did you want to talk a little bit about overall maintenance and updates of content?
Just to remind you, we're about out of our official time. We can keep the line open and we can answer a few more questions, but we are at time. I just want to acknowledge that for people who have planned their day.
Thank you, Dan. We can't hear you, Jonathan.
Oh, and thanks, Dana. I guess, and that's fine if people need to start dropping off. I'll go ahead and answer this question. Just one additional thought to add to what Andy said, which is, so for OCL specifically as a digital global good, we are supporting a community of terminology, and it is really up to organizations to curate and handle their terminology needs, and we're providing the tooling and supporting the community related to that. That said, we would love for our tools to be more supportive and actually facilitate best practices related to how do you propose a new concept? How do you propose changes to existing concepts or report maybe issues in something that you found? And so a lot of those features are either supported already or are on our roadmap to make this process even easier for people.
All right, and we are at the end of our time. I want to send another thank you to our panelists today for the absolutely great presentations and giving a glimpse into what we are thinking with National Health Data Dictionaries and hoping to provide some guidance for countries in the future. It sounds like I've been chatting with James Karaoke in the background. We might be having a follow-up session to this to answer some more specific questions. If that is what happens, then I look forward to seeing you all there. Please keep your questions for that time. And thank you all so much for your participation today. Bye,
Thank you all.
Yes, thank you, everyone. I will put up a brief slide if you've got a moment to let us know what you thought of this session. And again, we thank everyone for participating. We especially thank our presenters, and I do hope we can follow on soon. Also, we are scheduling webinars for the next few months, so if you have a thought about a webinar you'd like to present on, you can email us at shiriki@cdc.gov. So thanks, everyone, and we will see you again soon.